Hello friends, in this video we are going to talk about the post-streptococcal glomerulonephritis. It is a common disorder in the developing countries, most frequent in children between 6 to 10 years of age. It follows the streptococcal infection. Primary streptococcal infection usually involves the pharynx or the skin. Pharynx in the pharynx, pharyngitis, and in the skin, impetigo or pyoderma. Skin infections are usually associated with overcrowding and poor hygiene. Only certain strains of group A beta hemolytic streptococci are nephritogens. More than 90% are due to types 12, 4, and 1. These can be identified by typing of M protein of the streptococcal cell wall. Mean streptococcal antigenic component responsible for immune reaction is in the ESGN is the streptococcal pyogenic exotoxin B in most of the cases, but not all the cases. Manifest usually after a latent period of 1 to 4 weeks following primary streptococcal infection, meaning that after 1 to 4 weeks of streptococcal infection, your kidney problems will arise. Post-streptococcal glomerulonephritis is immune complex mediated disease. Latent period, as we have discussed above, is 1 to 4 weeks. Now antibodies against streptococcal antigens. They are increased in majority of patients. These antibodies are anti-streptolysin O, anti-deoxyribonuclease B, anti-streptokinase, anti-hyaluronidase, and anti-nicotinyl adenine dinucleotidase. These are the antibodies. Now hypocomplementemia is observed in more than 90% of patients due to activation and utilization of complement components by immune complexes. If you have to understand this mechanism in details, you have to understand the immunology part first. Now, immune complex deposits. Electron microscopy shows glomeruli with electron-dense deposits of immune complexes. And immunofluorescence shows granular fluorescence to the immune deposits. Here in this image, you can see the granular immunofluorescence. Some of the streptococcal antigens in the glomeruli is also seen, such as DNA PIR, nephritis associated streptococcal plasmid receptor, then streptococcal DAPDH, streptococcal pyogenic exotoxin B. We have discussed already. So the mechanism of damage. So what happens is that once the infection happened, it releases the antigens, and in response our body produce the antibodies. Now these antigen and antibody react with each other and forms the immune complexes in the circulation, and it will get deposited in the glomeruli. Now what happens that these immune complexes will initiate the inflammatory response, activating complement and other humoral and cellular mediators of inflammation. Now these inflammatory mediators attract active neutrophils and monocytes and stimulate proliferation of mesangial and endothelial cells. This result in hypercellular glomerulus. So this is the mechanism of damage. So it is other simple principles of the inflammation. So now let's talk about the morphology. The kidneys are enlarged, so pale capsular surface and cortex. Now If we talk about the microscopy, first we will talk about the glomeruli, enlarged hypercellular glomerulus. It is the classical diagnostic feature as we have discussed in the mechanism of damage also, which is seen in all glomeruli. So it is, hence it is called diffuse. See, first here you have to understand some of the terminologies. When focal means what? That less than 50% of glomeruli are involved. For example, focal segmented glomerulosclerosis. Okay. When diffuse is written or termed, then it means that greater than 50% of glomeruli are involved. Diffuse proliferative glomerulonephritis is an example. When proliferative means hypercellular glomeruli, as we are seeing in the PSGN. Okay, its example is proliferative glomerulonephritis. Then membranous means thickening of glomerular basement membrane, which is membranous nephropathy. Then primary glomerular disease. It is primary disease of the kidney, specifically impacting the glomeruli. Minimal change disease and secondary glomerular disease meaning that systemic disease or disease of another organ system that also impacts the glomeruli. Meaning that other disease which impact the kidney and also impacts the glomeruli specifically is secondary glomerular disease. SLE and diabetic nephropathy are the examples. Okay. Now let's come to the morphologic features. This hypercellularity is due to infiltration by leukocytes. It includes both neutrophils as well as monocytes. Okay, neutrophils as well as monocytes. And then proliferation and swelling of endothelial and mesangial cells. Rarely proliferation of parietal cells lining Bowman's capsule. It forms crescent. Presence of crescents is a poor prognostic feature. Now, obliteration of glomerular capillary lumen. It is due to swelling and proliferation of endothelial and mesangial cells plus infiltration by leukocytes. Tubules. It may contain red cell cast in the lumen and the tubular epithelial cells may show degenerative changes. Interstitium. Mesoedema and inflammatory cell infiltrator. Blood vessels unremarkable. Okay. Now, immunofluorescence microscopy. In the post-streptococcal glomerulonephritis, a granular immunofluorescence will be seen. We have discussed earlier. Granular deposits of IgG, IgM, and C3 complement in the mesangium and along the glomerular basement membrane. So, granular fluorescence is seen. Now, electron microscopy. In the post-streptococcal glomerulonephritis, subepithelial deposits on electron microscopy will be seen. Subepithelial deposits of discrete amorphous electron-dense deposits is characteristic feature. These appear as dome-shaped humps termed as humps or lumpy deposits. Okay, humps or lumpy deposits. They correspond to the granular IgG and C3 demonstrated by the immunofluorescence. Subendothelial intramembranous and mesangial deposits may also be present. Okay. The points you have to remember is that in the post-streptococcal glomerulonephritis, there is diffuse cellular proliferation of endothelial and mesangial cells and infiltration by leukocytes. Okay, and that leads to the obliteration of glomerular capillary lumen, and also they sometimes rarely proliferation of parietal cells lining Bowman's capsule. So it forms crescent, and crescent is a poor prognostic feature. So this some of the points you have to remember. Now, let's talk about the clinical course. The point you have to remember is that acute proliferative glomerulonephritis we present with the periorbital edema, mild to moderate hypertension, and cola-colored urine. Okay, mainly affect the child. Develops smallized fever, nausea, oliguria, and hematuria. Due to hematuria, cola-colored urine or smoky urine will be seen, and 1 to 2 weeks after recovery from a sore throat. Okay. Now we have discussed periorbital edema and mild to moderate hypertension is usually observed. Clinical features are atypical. Okay, now let's talk about laboratory findings. Raised anti-streptococcal antibody, raised streptococcal antibody titers, ASO titer, but the level may be low in glomerulonephritis that follows streptococcal skin infection. Okay, um, now hypocomplementemia, we have already seen it. Significant reduction in serum concentration of complement C3 components. Raised blood urea and serum creatinine indicate a renal impairment. Complement levels in post-streptococcal glomerulonephritis. Transient reduction during the disease, but a return to normal in 6 to 8 weeks. Urinary findings will oliguria, mild proteinuria, hematuria, okay, or cola-colored urine. We have already seen that. Red cell cast or dysmorphic red cells. Okay. Now hematuria with dysmorphic RBC are seen in acute glomerulonephritis. Okay. Now for prognosis, most affected children recover in adults. Prognosis is worse. So this is all about acute post-streptococcal glomerulonephritis. Okay. Uh, in the rheumatic fever or a rheumatic heart disease, the ASO titer is high, but in the post-streptococcal glomerulonephritis, ASO titer may be low. Okay, so this is for today. Hope you have enjoyed the video. Thanks for watching.